Hello everyone. Today we'll be discussing about the NIBP, non-invasive blood pressure, and this is monitored in patient monitors inside hospitals. To start with this non-invasive blood pressure monitoring, let's look into the explanation of or what is pressure. So the pressure can be said like it's an expression of force put on a surface per unit area. The force applied on a surface. So where what sort of pressure are we going to measure? So here when we say on a human body, the force of blood against artery walls is what we are going to measure now. The systolic, the higher number, and diastolic is the lower number. When normally everyone have seen these readings, systolic and diastolic. So what is the systolic? The higher number is the force of blood being pushed when your heart contracts, and diastolic pressure is the pressure when the heart relaxes between two beats. So and the cardiology division, or this cardiology based developments started from this knowledge, the knowledge of systolic and diastolic pressure. So that is the basement of all cardiovascular functions and identifying the disease, the heart diseases, everything that started from this systolic and diastolic knowledge. So if we look as a clinical engineer, our patient monitors do have a cuff which is tied to the upper arm and a BP is displayed. So all these are on the top of a principle or an idea called vascular unloading principle. That is the base of all occlusive cuff based methods which is used to determine the arterial blood pressure. The vascular unloading principle, so that is the fundamental to all occlusive cuff based pressure monitoring. Right, so what is this vascular unloading? So when we apply an external compression pressure, what happens? That pressure is transmitted to the underlying vessels. So what happens? Once an external pressure is applied to the vessels, so this vessel and the external pressures both comes to equilibrium. So both are in same pressure. So that is called that point, or that equilibrium, attaining that equal force or equal equilibrium is called vascular unloading. When more pressure is applied above this vascular unloading, the lumen closes, and when we release this, what happens? The lumen opens and the blood will start flowing through the vessel. In another way, we can say is like this vascular unloading is attaining the transmural pressure to zero. The pressure is the blood vessels are also zero, so that the pressure both in equilibrium, bringing or maintaining that is uh, vascular unloading. If you look into the present, all multi-para monitors, most methods that employ the occlusive arm cuff rely on this principle, this vascular unloading principle, and differ in the means of detecting whether the artery is open or closed. So, what there are few methods to find out whether the artery is open or closed. That there mainly two we will discuss further. So there are some approaches called that skin flesh, uh, palpatory, then oscillometric, ultrasound methods, and Krakow sound method. All these, out of all these, we will be explaining or looking into two methods. So majorly, that is that Krakow sound. Another one is oscillometric sound, oscillometric method. Now mostly all medical equipments or all patient monitors are following this oscillometric non-invasive blood pressure monitoring. Not only non-invasive, in invasive also, this method is what they follow. I'm sure everyone has noticed this cuff, NIBP cuff, and that is like designed to encircle the upper arm. Inside that, you can see a flat rubber bladder connected to a air supplying tube, right? The bladder is covered externally by a cloth material with a velcro so that it can be covered and tightened. So what this cuff does, this cuff should accurately transmit pressure down to the tissue surrounding the artery. The mechanical analysis revealed that the length of the cuff is required to be specific fraction of arm's circumference for pressure equilibrium, and this is the reason why you see different sizes of NIBP cuffs. You can see for adult, pediatric, neonatal, and in adult you can see a triple XL, or for obese patients and different things. So that is the reason the measurement, what it says is the circumference ratio, it should be 0.4 should be maintained. That means it should give a equal distribution of pressure, and the same pressure should be transmitted into the deeper tissues to come to this vascular unloading and to come to this equilibrium. So this concept is very important for the accurate measuring of NIBP. A narrow cuff or an inappropriate size cuff, it can bring in or in it can bring greatest error in pressure transmission, and because of that the greatest error in blood pressure determination by the sensor or even the pressure transducers of these patient monitors. The cuff mechanism is the important part in the measuring. If you see, like you can see when the cuff, when the pressure is released, The cuff shape deformation proceeds at low pressure until the bladder reaches its final geometry, and it gives you a pressure volume relationship, right? A curved sort of graph. And when you put on a high pressure, that results in a linear relationship graph. So this model was useful in linearizing the curve for use of plethysmograph. Now let's look into the methods, the Krakow and the oscillometry methods, the two major methods which we need to know about an NIBP measurement or a blood pressure measurement. So when you do a manual blood pressure measuring, how it is like we will be tying the cuff on the upper arm, and nurses used to keep a stethoscope and they observe a sound, a heart sound. So that method is this Krakow method basically. The cuff is inflated above the systolic pressure and then allowed to deflate at a rate of 2 to 3 mmHg. With falling cuff pressure, sound begins and slowly changes its characteristics. I think if you got any chance to observe this, you can really relate to what I'm saying, or you can understand what is this Krakow method. So in this Krakow method, there are 6 phases. The first phase is like when you release, once you put high pressure on the cuff and above the systolic pressure, and when you start releasing it, you will get a sound. The first, when you release, that is phase 1, which is the Krakow sound and denotes systolic pressure. When you hear the first sound, the second phase, the sound increases its loudness. Third phase, the maximum intensity occurs. And the fourth phase is Krakow sound is identified and as muffled sound. And fifth is a complete disappearance of sound. And sixth phase is normally 2, not a diastolic pressure. The few problems of this Krakow method is it underestimates systolic pressure by around 5 to 20 mmHg and overestimates the diastolic pressure by 12 to 20 mmHg. In spite of these errors, the method of Krakow is considered a documented non-invasive blood pressure standard by which other non-invasive methods are evaluated. So how in normal hospital practices is when for critical care, especially for ICUs, the nurses, they take this manual BP and compare the machine BPs, and if they observe any drastic change, they may call clinical engineers for the correction. So how the clinical engineers does is they take a stimulator with them and stimulate this machine with the same pressure and see whether the monitor is attaining the same, and this validated. And the calibration process is even bit complicated that we will come to later. So the second method is, which we are going to discuss, is this oscillometry. So oscillometry is performed using a standard arm cuff together with an inline pressure sensor. What makes difference is the crock-off depends on the sound and oscillometry depends on the inline pressure sensor. So what happens? The recorded cuff pressure is high pass filtered above 1 Hz to observe the pulsatile oscillation as the cuff slowly deflates, and the systolic pressure is located at the point where the oscillations are a fixed percentage of maximum oscillation. In this graph recording, you can see the topmost green waves are ECG waves. The middle red one is the pressure sensor waves, and the blue one is the cuff pressure. So you can see here when the cuff is taken to the maximum pressure and it's allowed to deflate. At this point you can see it's dropping down and the it's starting the pulse, so that is diastolic, and it's again dropping down. Then we will release the pressure and you can see it's dropping. The red graph is dropping down automatically and again coming to a baseline where the vascular unloading is happening. The blood is allowed to flow freely and the pulse is stopping. So that is the diastolic. So this is how the monitor is reading the NIBP. Manufacturers of NIBP monitors use the oscillometric technique. In ICUs, you can see two categories of pressure monitoring: invasive and non-invasive. The invasive approach, it inserts a catheter into an artery of the patient. The catheter may contain a pressure transducer at the tip, or it may be a fluid filled and couple the blood pressure through this fluid to an external transducer. The change of fluid pressure in the subject's artery is said to be measured invasively, and this is also known as this direct measurement because the parameter being measured is directly coupled to the transducer. The other one, as we discussed, is the non-invasive technique, which can be realized several ways. It usually involves to use an inflatable and a cuff wrapped around the limb of the patient. The cuff is inflated, deflated, the entire procedure we discussed before. And this is an indirect method called as. So this direct and indirect is invasive and non-invasive. Discussing about the hardware part of NIBP module, it consists of a cuff, and the cuff tubing is connected to a pressure transducer, and the output of the pressure transducer is to the analyzing unit, and this analyzing unit throws the digits on the screen where we will read the diastolic and the systolic. So this pressure sensor is the main part, and this pressure sensors basically it's a strain gauge sensor. Maybe inside this NIBP module it may be using a piezoelectric strain gauge pressure sensor. So once when the a small changes or when the pressure is exerted into the sensor, it senses, and this mechanical energy is converted to electrical energy, and that sensor's electrical output is given as an input to the analyzer, and the algorithm, it identifies these pulses and rates the systolic and diastolic for us and displays on the monitor. And this is the basic hardware part. By this I'm winding this video. Guys, please post your comments. If any corrections, please write to me on my email ID. And if you would like to hear anything more about this or any sort of explanation, clarification required, please write to me, and do follow the channel for further equipment updates.